Today, the 1619th day of uninterrupted daily webinar of IFPH is about to begin. And today our guest is Dr. ANJU Roy from Qatar. Dr. ANJU Roy graduated from Sharada Krishna Homeopathic Medical College, Kulashekharam, Kanyakumari, and worked at Sri Homeo Clinic for 6 years. Worked in DHD Munnar, DHD Munira, and District Hospital Muttam, Todupuzha on a contract basis. Currently, she is practicing in Qatar. Today, the topic is understanding vitamin D, its deficiency and its homeopathic management. Yeah, now you are co-hosts that you can share.
Already shared, sir. I hope you can see it.
Okay.
Are you able to see, sir?
Yeah, it's visible.
Okay. So, good evening, all. Before we begin, I would like to express my heartfelt thanks to IFPH team for giving me this wonderful opportunity to speak today. I would also like to extend my gratitude to Abdul Salam sir for encouraging me and inviting me to this session. Thank you, sir. Thank you so much for your support. And now let's dive into today's topic, vitamin D deficiency and its homeopathic management. So let's get started. Why do I select this topic? Because today, a large number of people, especially, am I audible? Hello?
Yes, you are.
Yeah. Yeah. So today, a large number of people, especially those who are living in the Middle East and northern latitude, are suffering from vitamin D deficiency. This is a growing concern due to various factors such as limited sun exposure, lifestyle choices, and dietary habits. Given its impact on overall health, I felt it was important to address this issue and explore how homeopathy can help effectively for the management strategies for vitamin D deficiency. So, I look forward to engaging with all of you throughout the session. So, for making this session more interactive and engaging, I would like to present a case. Understanding the correct diagnosis is crucial before selecting the appropriate homeopathic remedy. Even though we are giving more importance to the to individualization, as we go through this case, please stay attentive and try to identify the diagnosis. So at the end of this session, we will discuss about the homeopathic approach to this condition. So the case is a 3-year-old kid brought to our clinic with chief complaint of difficulty in walking, bowing of legs, delayed dentition, and dental caries. He already consulted a physician and he's under the treatment of oral vitamin D for past 6 weeks. And as per his mother, his dietary habits are normal. The child was prescribed with placebo and he referred to lab investigation. So the biochemical investigations were done and the report says alkaline phosphatase is increased. Alkaline phosphatase is increased. Serum calcium and calcidiol level is normal. Then PTH level is normal. Then serum phosphate level is decreased. So I repeat, alkaline phosphate level is increased. Serum calcium and calcidiol is normal. PTH level is normal, and serum phosphate level is decreased. What could be the probable diagnosis? Definitely, it's a vitamin D deficiency, but we can see what type of vitamin deficiency. We will discuss the case later. So, vitamins. Vitamins are a group of substances, especially that are organic compounds that are needed for normal cell function, growth, and development. Depending on the solubility, vitamins are classified into two types: water-soluble vitamins and fat-soluble vitamins. The water-soluble vitamins are, these all are the basics, but I just repeat. The water-soluble vitamins are vitamin B complex vitamins and vitamin C. The B complex vitamins include B1, B2, B3, B5, B6, and B12. And the fat-soluble vitamins are vitamin A, D, E, and K. These water-soluble vitamins cannot store in our body and excreted through urine. So they need to be replenished regularly through diet. And the fat-soluble vitamins, they can be stored in our body. It dissolves in fat and it can be stored in our body for a long time. We can come to our topic proper. This is vitamin D. It's a, as we told, it's a fat-soluble vitamin. And these are obtained with the help of fat, absorbed with the help of fat, and are stored in the body's liver and fat tissue. They are typically not excreted in urine, which means they can accumulate in the body if it is taken in excess. So the vitamin D is a fat-soluble vitamin and it has a steroidal compound. It's also called sunshine vitamin and anti-regetic factor. It's a fat-soluble vitamin, as we told earlier. It can be stored for a long time and it also has steroidal compounds. Vitamin D has two major forms. It has many forms and the two major forms are vitamin D3 and vitamin D2. Vitamin D3 is otherwise called as cholecalciferol. It's the endogenously synthesized form, that is 7-dehydrocholecalciferol. And vitamin D2, it's a commercially obtained form of vitamin from the fungus ergot. Why it is called as sunshine vitamin? Because of its endogenous production under the influence of sun, then it has a potential to cure regetic symptoms. So it's called as anti-rachitic factor. Obviously, there is a controversy going on for many years, like whether it is a hormone or vitamin. For many years, it has been told us vitamin, but recent advancement tells us the active form is a hormone. It can be, why? It can be synthesized in our body. After synthesis, it's released into circulation. It has a distinct target organ like intestine, bone, and kidney. Its mechanism of action is similar to steroid hormones. It acts through the nuclear receptors. Then, levels are always subjected to feedback mechanisms. However, we can't tell it as a hormone because it's not secreted by a gland from our body. So the controversy is still going on. Then about the sources of vitamin D. We can see the first and major source is the sunlight exposure. Sun exposure is the most natural and effective source of vitamin D. The skin produces vitamin D when exposed to ultraviolet B rays. When UVB rays hit the skin, a chemical reaction occurs that produces vitamin D3, that is cholecalciferol. Few factors to be considered while getting sun exposure: the amount of sunlight, the amount of sun exposure needed depends on factors like location, that is latitude, then about the skin tone, then time of the day and season. Typically around 10 to 30 minutes of sun exposure several times a week can help maintain adequate vitamin D levels. Best time to get sun exposure for vitamin D production depends on several factors, including the time of the day, geographical location, and the skin type. However, in general, the most effective time of vitamin D synthesis is when the sun is at its peak, as this provides the most direct ultraviolet B rays. Best time of sun exposure. A common misconception is that early morning or evening, that near the sunset, that sunlight is the best for vitamin D production. That's the misconception. Many people still believe that this because the sunlight is thick and softer light in the early morning and the late evening is softer and gentler for the skin, but these times are actually not ideal for vitamin D synthesis. Many patients are still believes that the early morning sunlight or late evening sunlight is essential for the vitamin D synthesis. So still the misconception is there. Let me explain the science behind why midday sun exposure is most effective and why early morning or sunset sunlight doesn't work, as well as for vitamin D production. Why midday sun is best for vitamin D? Because ultraviolet B rays, the key to vitamin D production is ultraviolet B radiation from the sun. Ultraviolet B rays are most effective when the sun is directly overhead, typically between 10 a.m. and 3 p.m. This is the exact timing for the sun exposure for getting the adequate vitamin D, between 10 a.m. and 3 p.m. During this time, the rays are strongest and the skin can absorb the ultraviolet B rays more effectively. Angle of sun. In the early morning and evening, the sun rays have to pass through a thicker layer of the atmosphere, which filters out a significant amount of the ultraviolet B radiation. This is why the sunlight at those times isn't as effective for producing vitamin D. In contrast, when the sun is at its peak, that's the midday, ultraviolet B rays comes directly down, providing the most effective exposure for vitamin D production. During midday, typically between 10 a.m. and 3 p.m., ultraviolet B rays are at their strongest and most direct. This is when the body can produce the highest amount of vitamin D in the strongest amount of, in the shortest amount of time. If you have a fair skin, about 10 to 30 minutes of direct sunlight during midday can provide sufficient vitamin D production. For darker skin tones, more exposure may be required due to higher level of melanin, which blocks ultraviolet B rays. How to safely get vitamin D from the sun? Moderate sun exposure. Also, we have to avoid the overexposure. See, moderate sun exposure, the aim for 10 to 30 minutes of sun exposure a few times a week, depending on your skin type and where you live. If you are outdoors for longer periods, make sure to protect your skin with sunscreen or clothing to prevent sunburn or skin damage. Then avoid overexposure. While midday, sun is most effective for vitamin D, but don't overdo it. Long sun exposure can increase the risk of skin damage and it may cause cancer also. So limit the direct sun exposure to about 15 to 30 minutes for adequate vitamin D synthesis. And we can use the sunscreen after the exposure as well. Then about the food source of vitamin D. Since it is sufficient to get enough vitamin D from food alone, it's difficult to get. So from the dietary source, and typically a supplement option alongside of, only a supplement option alongside of the sunlight. Then animal-based sources are Animal-based source, from the animal source, we will get the vitamin D3, that is cholecalciferol, especially fatty fishes like salmon, mackerels, tuna, sardine, and these are the some of the best source of vitamin D. Then cod liver oil. Cod liver oil is the richest source of vitamin D. Then egg yolk, especially the yolk. It contains a modest amount of vitamin D. Then liver. Beef liver is another source, though not as rich as fatty fish. Then fortified dairy products like milk, cheese, and yogurt are often fortified with vitamin D. Fortified foods like some brands of orange juice, cereals, plant-based milks like soy and soy milk, almond, etc. are fortified with vitamin D. Then plant-based sources, vitamin D2, that is ergocalciferol, we will get from plant sources. Mushrooms, as it is getting exposure to ultraviolet rays, mushrooms are growing outside and it's getting more ultraviolet rays. So certain mushrooms, this provides vitamin D2, which is not as potent as D3, but it's still beneficial. Then we can see about the recommended daily allowance, RDA. It varies based on the factors like age, sex, and life stages, like pregnancy and breastfeeding. So we can see for infants, that is 0 to 12 months, we call it as infants, and daily recommended allowance is 400 international unit. Then for children between 1 to 18 years, it's 600 international unit. And for adults up to 70 years, it's 600 international unit. And for old age, that is above 71 years, it's 800 international unit. And for pregnant and lactating women, it's 600 international unit. These are from the recent ICR guidelines, these ranges. Then about the the signs of deficiency, we can see fatigue, bone pain, muscle weakness, increased risk of fracture, immune system dysfunction, etc. Now we can see the synthesis of vitamin D from skin. It's a natural process that occurs when ultraviolet B rays from the sun interact with the skin. When it happens, they're absorbed by the epidermis, that is the outer layer of skin. We have 3 layers, epidermis, our skin. It's epidermis, dermis, and hypodermis, as we all know. And again, for epidermis, we have 5 layers: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. That is the basic layer. So the first layer, stratum corneum, when it gets exposure to sun, the process begins. The epidermis, the synthesis happens in the stratum corneum level. That's the outer layer. Then the cholesterol derivative known as 7-dehydrocholecalciferol, that is the pre-vitamin. This is the pre-vitamin, this 7-dehydrocholecalciferol. When exposure to this ultraviolet B rays, it forms a pre-vitamin. When it exposure to sunlight, especially UV rays in the wavelength of 290 to 315 nanometer, it converted to cholecalciferol, that is vitamin D3. And this process is called as thermal isomerization. So, because of this thermal isomerization, it will convert to vitamin D3. Vitamin D synthesis is directly proportional to exposure to sunlight, and it is indirectly proportional to pigmentation of skin. Now we can see the metabolism of vitamin D. Conversion into an active form that can be utilized by the body. The process takes place primarily in the liver and kidney. Vitamin D can be obtained either from sunlight, diet, or supplement, as we told, as it is metabolized in several stages to become calcitriol. Calcitriol is the most active form of vitamin D, which plays a crucial role in maintaining calcium and phosphorus balance in the body. From the dietary sources, ergo calciferol, that is vitamin D2, D3, via lymphatic system, it reaches the liver, reaches the circulation, bind to plasma alpha-1 globulin, that is the D-binding protein, it reaches the liver. Through the circulation, it reaches the liver. And in liver, cholecalciferol is hydroxylated to form calcidiol by an enzyme called 25-hydroxylase. This calcidiol is the main storage form of vitamin D. So the main storage form is vitamin D is calcidiol. Again, it is released back to circulation, bind to debinding protein and reaches the kidney. In kidney, calcidiol is again hydroxylated. Once in the liver, cholecalciferol is hydroxylated and it is formed calcidiol. In kidney, it's again objected to it's hydroxylated to this calcidiol is hydroxylated to form calcitriol by an enzyme 1-alpha hydroxylase. This is the most active form of vitamin D. So the main storage form of vitamin D is calcidiol, and main active form is calcitriol. Calcitriol is released into circulation back and now reaches the effective organs. After vitamin D synthesis in the skin, it ingested through food or supplements, it's carried to the liver, as we told. Then what happens when plasma calcium level decreases? So when plasma calcium level decreases, it will influence the it will causes secondary hyperparathyroidism, and it stimulates the parathyroid gland, and it causes increased expression of parathormone. It has two main functions. One is it favors expression of 1-alpha hydroxylase enzyme in the kidney. So there is increased production of calcitriol, we have seen earlier. Along with calcitriol, they mobilize calcium from bone. So it will increase the calcium mobilization from bone and increase renal absorption of calcium, and decreased renal excretion of calcium, increased reabsorption from kidney and decreased excretion from kidney. Then it will causes increased absorption from intestine. It helps to absorb from intestine. This will helps to increase this way it regulate the plasma calcium level. So now we can see the metabolism of molecular mechanism of vitamin D. Regarding this, vitamin D, that is calcitriol, you can see in this picture. Molecular mechanism of vitamin D. Through this picture, we can understand it. Regarding this, vitamin D, that is calcitriol, this one goes to the cell. In the cell membrane, cytosol. In cytosol, that is the nuclear membrane. This is nuclear membrane, and this is a receptor. There is a receptor known as vitamin D receptor. This one, vitamin D receptor, and it is embedded in the nuclear membrane. Once vitamin D gets bind to vitamin D receptor, this complex get into nucleus. This vitamin D receptor get dimerized with a retinoid X receptor. Once this two receptor get dimerized, they go and bind to an area known as vitamin D response elements, VDRE, this one. Once this is activated, there is transcription and transition happens, and finally production of proteins. It has many proteins are there, but the main one is cal binding. So the cal binding is essential for the calcium absorption that we will see later. Then about the functions, main function, regulation of calcium and phosphorus balance, phosphate balance, bone health and mineralization, immune system modulation, muscle function, cardiovascular health, insulin regulation and diabetes management, skin health, cognitive function and mood regulation, hormonal regulation and cancer prevention. Regulation of calcium and phosphate balance. Calcium absorption. One of the most well-known function of vitamin D, especially the active form we already told, calcitriol, is its role in regulating calcium absorption in the intestine. It enhances the absorption of calcium from food, which is essential for maintaining strong bone and teeth. Sorry. Phosphate absorption. So calcium absorption we have seen, and then the phosphate absorption. Vitamin D also helps in the absorption of phosphate. Another mineral that is vital for bone health and metabolic function. Together with calcium, phosphate contribute to bone mineralization and the formation of hydroxyapatite crystals, the mineral component of bones. Then about bone health and bone mineralization. Vitamin D plays a vital role in the growth and development of bones by promoting the proper mineralization of bones and teeth. Without adequate vitamin D, bones can become soft and fragile, leading to conditions like rickets in children and osteomalacia in adults. We will see it later. And bone remodeling. Okay. Vitamin D influences the process of bone remodeling, the continuous cycle of breaking down and rebuilding bone tissue. It helps ensure that bone formation and resorption are balanced, which is essential for maintaining bone density. Then about the immune system modulation. Immune function. Vitamin D is important for the immune system. It helps activate immune cells like T cells and macrophages, which are involved in defending the body against infections and pathogens. Adequate level of vitamin D may help reduce the risk of infections, particularly respiratory tract infections. Then about autoimmune diseases. Vitamin D has been shown to play a role in modulating immune responses and may reduce the risk of autoimmune diseases like multiple sclerosis, type 1 diabetes, and rheumatoid arthritis by regulating immune cell activity and preventing excessive inflammation. Then muscle function. Vitamin D is necessary for muscle strength and function. It helps muscle cells take up calcium, which is crucial for muscle contraction. Low level of vitamin D are associated with muscle weakness and increased risk of falls, particularly in elderly people. Researchers have shown that vitamin D supplementation can improve muscle strength, reducing the risk of fall in older adults and improving mobility. Then about the cardiovascular health. Vitamin D is involved in regulating the function of the heart and blood vessels. It helps maintain proper blood pressure by influencing calcium metabolism in the blood vessels and by modulating the renin-angiotensin system, which is involved in blood pressure regulation. Some studies suggest that vitamin D deficiency may be linked to an increased risk of heart diseases, hypertension, and stroke, though more research need to fully understand this condition and its connection. Then about the insulin regulation and diabetes management. Vitamin D plays a role in insulin secretion and insulin sensitivity, which are crucial for regulating blood sugar level. Adequate vitamin D may improve insulin sensitivity and helps in the management of type 2 diabetes. I have seen many cases with those who are suffering from type 2 diabetes mellitus are suffering from low vitamins. So we can see here it improves the insulin sensitivity and helps to manage management of type 2 diabetes mellitus. There is growing evidence that vitamin D deficiency may be associated with an increased risk of developing type 2 diabetes and other metabolic disorders. Then about the skin health. Vitamin D has a positive effect of skin health. It's involved in the process of cell growth and repair, and it may help prevent certain skin conditions such as eczema, psoriasis, and acne. Vitamin D is also thought to play a role in wound healing, as it helps in the regeneration of skin cells and tissue. Then about the cognitive function and mood regulation. Brain health. Vitamin D receptors are found in several areas of brain, and vitamin D is believed to play a role in cognitive function and mental health. Depression. Low level of vitamin D have been associated with a higher risk of depression and other mood disorders. Some studies suggest that adequate vitamin D levels may help improve mood and reduce symptoms of depression, though further research is needed. Hormonal regulation. Vitamin D acts as a hormone in the body, especially calcitriol is in the active form. It helps regulate the balance of parathyroid hormone PTH, insulin, and other hormones. We have seen the insulin, the effect in diabetes mellitus. By regulating these hormones, vitamin D indirectly influences various metabolic processes and promote overall health. Then it also tells that cancer prevention, it has a potential role. Some studies suggest that vitamin D may have a protective effect against the development of certain type of cancer, particularly colon, breast, and prostate cancer. It is thought that vitamin D may inhibit the growth of cancer cell by promoting cell differentiation and reducing inflammation. So the vitamin D assay. Since the main storage form is calcidiol, its serum level is estimated for assessing vitamin D status. So the normal range is between 30 to 100 nanogram per ml, and the insufficient range is between 20 to 29 nanogram per ml. And the deficiency we are calculating between the means below 20 nanogram per ml. Now, deficiency of vitamin D. Deficiency of vitamin D in children, we call it as rickets, and in adults, we call it as osteomalacia. The causes of vitamin D deficiency is, as we told, it's inadequate sunlight exposure, then about the malabsorption conditions, also chronic liver and kidney diseases. Inadequate sun exposure, first one. Why it's happened? Because chronic, it happens in chronic bedridden patients, also in the habitat of northern latitude, also covering whole body always. That the women's ladies are using pardas for a long time in that cases. Then then malabsorption conditions like chronic inflammatory diseases like Crohn's disease, then post gastrectomy. Then the third one is chronic liver and kidney diseases. In these conditions, there is a deficiency of vitamin D. Now we can see rickets. Rickets is seen in children. Insufficient mineralization of bone before the epiphyseal closure. If it is after the epiphyseal closure, we call it as osteomalacia. Bone becomes soft in rickets. Bone becomes soft and pliable, so it causes bone deformities. Mainly weight-bearing bones are bent up. It causes bow leg and knock knee, bossing of frontal bones, then craniotabs, pigeon-like chest, beading of ribs. That is the rachitic rosary. Then Harrison sulcus we can see in X-ray finding. Harrison sulcus, that is indentation of lower ribs at the site of diaphragm attachments. Weight bearing. So the weight bearing bones are affected. It causes bow legs and knock knee, bossing of frontal bones, craniotabs, pigeon-like chest, beading of ribs, that is rachitic rosary. Then indentation of lower ribs at site of diaphragm attachment, that is known as Harrison's sulcus. Here in this picture, we can see the pigeon. Here this is pigeon-like chest, pectum. We called it as pectum excavatum. Pectus carinatum, that is pigeon chest, pectus carinatum, softening of ribs. They bend inwards. The respiratory muscles causes anterior protrusion of sternum, appears like pigeon chest. Then beading of ribs. In this picture, we can see the beading of ribs, beaded-like appearance. That is the prominence of this costochondral junction causes this beaded-like appearance. Pulling of ribs in the inspiration, that is Harrison sulcus. Then frontal bossing. Failure to closure of anterior frontanale causes frontal bossing. In X-ray findings, we can see the cupping of metaphyseal ends of radius and ulna. It resembles the wine glass appearance. So it called as, it resembles wine glass appearance, Cambridge glass appearance in the lower end of ulna and radius. Craniotypes, important and earliest sign in newborn. Softening of cranial bones. When we apply gentle pressure, we can appreciate a dent mainly in the occipital and parietal area. The types of rickets. Nutritional deficiency rickets, vitamin D dependent rickets. Pathology is either with gene encoding for 1-alpha hydroxylase or with vitamin D receptor. Can be corrected by supplement of vitamin D. Then the third one is vitamin D resistant rickets. The pathology is increased phosphate excretion. Then the fourth one is renal rickets from chronic renal failure. Nutritional, first one is nutritional deficiency ricket. Most common cause of rickets globally in children. The biochemical changes are vitamin D deficiency. So serum calcium and phosphorus level will be low. It stimulates vitamin D deficiency, serum calcium and phosphorus level will be low. It causing secondary hyperparathyroidism. So the PTH level is high. The increased alpha hydroxylation happens in kidney. So 125D level will be increases. This will increase the serum calcium level, but phosphorus level remains at low level. Serum calcium level is variable. Serum phosphorus level is low. Serum PTH level is increases. 25D is decreased. 125D, that is calcitriol, is low initially, but later increases due to secondary hyperparathyroidism. This will help to increase the serum calcium level, but phosphorus level will be low. Then about osteomalacia. It's seen in elderly people, as we say, inadequate mineralization of bone after epiphyseal closure. Before it is rickets, after epiphyseal closure, it's osteomalacia. It's seen in elderly people. Bone pain, proximal myopathy, softening of pelvic bones, it causes waddling gait and recurrent fractures. Bone density will be low. It will cause recurrent fractures. Osteomalacia is the adult counterpart of rickets. It refers to the softening of bone due to defective bone mineralization, usually causes by vitamin D deficiency. The most common cause due to insufficient sunlight exposure, poor diet or malabsorption disorder that prevent the body from absorbing vitamin D effectively. Then calcium deficiency. Lack of calcium can lead to weakening of bones. Chronic kidney diseases. Kidney issue can lead to abnormal metabolism of vitamin D, resulting in osteomalacia. Medications, certain drugs such as anticonvulsants can interfere with vitamin D metabolism, increase the risk of osteomalacia. Malabsorption disorder, conditions like celiac diseases or Crohn's disease that impair the absorption of fat-soluble vitamins can lead to vitamin D deficiency and osteomalacia. The symptoms are bone pain. The most common symptom of osteomalacia is deep bone pain, especially in the lower back, hip, pelvis, and legs. Muscle weakness, weak muscles, particularly in the legs and arms. Fractures, weakened bones are more prone to fractures. Difficulty walking due to bone pain and muscle weakness. Affected individuals may have difficulty walking or maintaining balance. Waddling gait, due to hip weakness, people with osteomalacia may develop waddling gait. Diagnosis, the blood test, low level of calcium and phosphate and high level of alkaline phosphatase. That's a marker of bone turnover, are often seen in osteomalacia. X-ray shows changes in bone structure such as looser zones, radiolucent areas in bones. Bone biopsy. In some cases, the bone biopsy may use to confirm the diagnosis of osteomalacia. Bone mineral density, BMD testing, to assess the extent of bone loss. Treatment supplements we can recommend high dose of vitamin D to restore normal level and improve bone mineralization along with our medication. Calcium supplementation to address calcium deficiency and support bone health. Then phosphate supplementation. In some cases, phosphate may also be prescribed to correct the deficiencies. Sunlight exposure to encourage natural vitamin D synthesis. Dietary changes, eating food rich in vitamin D, such as fortified dairy products, fatty fish, and egg may be helpful. Addressing underlying conditions. If osteomalacia is secondary to kidney disease or malabsorption disorder, those conditions needs to be managed as well. Both rickets and osteomalacia are related to poor bone mineralization, but they occur at different stages of life. Rickets primarily affect children and is characterized by bone deformities, while osteomalacia occur in adult and lead to bone pain and muscle weakness. Both conditions are caused by vitamin D deficiency, but they can also be influenced by deficiencies in calcium and phosphate. Treatment for both condition typically involves addressing the underlying nutrient deficiencies with vitamin D, calcium, and sometimes phosphate supplementation, along with lifestyle modification like increased sunlight exposure and dietary changes.
Doctor, we are having only 6 more minutes to conclude, and I think
we can summarize the section and we can discuss that case as well, sir.
The thing is, we might not have another 3 minutes for you to finish the session, because after that, only 2 for 9:30.
Okay, so shall we conclude?
Yeah, we need to conclude, because some persons will be there to speak to us. Maybe some interaction round is necessary.
Okay, sir. Okay, sir.
So
before ending this session, hypervitaminosis, increased intake, increased dietary intake can causes hypervitaminosis. Symptoms are hypercalcemia, hypercalciuria, renal calculi, loss of appetite, calcinosis in blood vessels. Let me get one minute, sir. I'll conclude. We can see this case, that 3-year-old kid with bowing of legs, delayed dentition, and dental caries. As we already told, the dietary habits was normal, and even after the vitamin D prescription, the child didn't get better. So the biochemical investigation shows alkaline phosphatase increased, serum calcium and calcidiol normal, PTS normal, serum phosphate decreased. What be the 4 possibilities are vitamin D deficiency ricket, vitamin D dependent rickets, vitamin D resistant rickets, and renal rickets. Obviously, based on the chief complaint, difficulty walking, these points, the patient is having a kind of rickets, definitely, but vitamin deficiency dependent resistance and renal rickets we can avoid, because he is taking the adequate medication. The history of the patient was probably a ricket, so it's not having vitamin D deficiency, we can see, because patient is taking already medication. Now we can see the investigation. Alkaline phosphatase is increased and it is the bone marker. If it is elevated, there should be a pathology in bone, alkaline phosphatase. And serum calcium and calcidiol levels are also normal. Serum calcium and calcidiol is also normal. So the vitamin D deficiency rickets, and it's definitely it is a vitamin D resistant rickets. The patient be vitamin D deficiency rickets, serum phosphate level is decreased. And this is the important hint in the clinical history. It indicates that some form of phosphate is getting excreted in from the body. So probably it could be vitamin D resistant rickets. That is not renal rickets. There is nothing. There is no other renal pathology, and it maybe any renal pathology should be there for renal rickets. There will be decreased function of renal filtration, and this will be hyperphosphatemia in renal rickets. Here we have hypophosphatemia, seen in phosphate level is decreased. So the diagnosis is vitamin D resistant rickets. So we can see the homeopathic medication. Shall we do it as a discussion, sir?
We need a little bit of discussion also for the session, and let us conclude now.
Yes, sir.
So
Medicinal
it is a very
participants
interesting,
actually.
informative session, and it's very detailed, elaborate, and very much informative indeed. And so we'll be having someone to interact. Persons can hand raise that we can invite you to interact with the speaker. And here is Dr. Amir Malik, and let me see.
Hello, Honorable Dr. Anju Roy. Excellent session, Honorable Doctor. Grand welcome and warm wishes to you on IFPH panel. And Honorable Sir Abdul Salam always select the diamonds from the world and they bring them onto IFPH platform. I'm really thankful to you for your session, but I request you that you make it the part 2 for the vitamin deficiency D3 and the concerned diseases and the concerned medicines. To overcome the deficiencies due to vitamin D3 is a big issue. You know, the children suffering from rickets and the patients suffering from thyroid. And very important point, because it's this specialty is only in homeopathy that we have the medicine for parathyroid gland. You know, the sodium and calcium synthesis is always done in the parathyroid. And the very biggest thing, the very biggest mystery in the world is that, you know, the liver of fish is very good source to overcome the deficiency of vitamin D3. And you may be surprised, you just check the fish markets, there is no liver in any fish. When they sell the fish, I asked so many for salesmen that where is the liver? So I was just shocked, there is no liver in the fish. They said it is not there when we purchase. This is without two things. One is the liver, and second is the that the fish can float in the sea due to that a big bag like plastic. Wind is there in it. I don't know what is the name of that, unfortunately. But that is very important. Mother feed is very important. Our medicine Oleum jaculus is very important. You know, the mother tincture have a great effect to recover the deficiency of vitamin D3, and to have to see how could we overcome one also the one biggest miracle of vitamin D3, that during the COVID, you know, to boost the dead patient when the immunity is dead.
Doctor. Having.
We will talk later, sir.
Yeah,
Make
we
it part
need to,
Honorable
to
Dr.
conclude.
Anju.
Thank you for the additions. Thank you for the additions.
Yeah,
And we
okay. I
have
will stop
another
here. God bless you. Very
Dr.
good session.
Venugopal with us to interact. Doctor, please.
Yes, sir. I'm sorry.
Hello.
May you repeat
Hello.
it?
Hello.
No,
Can
Dr.
you hear?
Venugopal is need to.
Can you
talk.
hear?
Yeah.
Can
Sure.
you? Hello, Dr. Anju.
Hey, sir. Good evening. How are you,
Happy
sir?
to see you. Happy to see you.
Yes, sir. After a
once
long time.
again. So, and congratulations on your fantastic presentation.
Oh,
Your
didn't get enough time
insight
to.
on vitamin D were truly enlightening and very informative. I particularly appreciate your discussion on the importance of vitamin D in mental health. Of course, on other part also, but mental health, it is very you included the latest developments in the researches, and I think it's a very wonderful treatment. Your hard work and your expertise in the topic. Once again, I congratulate you, and I would love to see you again as a follow-up presentation on the particular applications of vitamin D.
Thank you, Dr. Venugopal. Thank you. And this time to conclude the session. Let me welcome Dr. Srilashmi for the vote of thanks.
Thank you, sir. Am I audible, sir?
Yes.
Good evening, everyone. Today I'm here to express my sincere thanks to Dr. Anju Roy for your detailed explanation on the topic vitamin D deficiency and its homeopathic management on the 1619th day of our IFPH webinar. You explained well about its sources, types, functions, and deficiency diseases, and remind us about the time to expose in sun is in between 10 a.m. and 3 p.m. And thank you, Dr. Anju, again for the detailed presentation. And I would like to thank all the doctors and homeopathic lovers for making everyday classes in IFPH so much enthusiastic and wonderful with uninterrupted webinars. I thank all the participants present here today, and a special thanks to Saram sir for trusting us and giving us opportunities again and again. Thank you all.
Thank you, doctors, lovers, and students of homeopathy. And time to hand over the session to Malayalam. Over to Malayalam. And tomorrow we will have the international session on the same time. See you all. Bye.